Good afternoon, everybody. We are here today to talk about FTCA issues. Like in the previous webinars, just the commercial at the beginning, we are doing a lot of these webinars. If there are topics that you'd like to hear that we have not yet covered, please let us know so that we could gear our webinars towards those topics. We are going to talk today about FTCA. For those of you who heard me speak, I think it was in the summer at the New Jersey Primary Care Association event in Atlantic City, some of what we talk about today will be a repeat from there, but what we're going to try to focus on today is not just what the requirements are, what for the application, what you practically need to be doing. Okay, so just stepping back for a second, remember FTCA is the coverage that FQHCs have, which relate to medical malpractice type claims that are brought against you, which obviously is very valuable to you because it allows you to avoid having insurance, although some FQHCs have gap insurance. The FTCA covers the FQHC and each of its employees. We will talk about today that they've actually now put a process in place where it could cover volunteers, and also can cover certain independent contractors in limited situations. We're not going to go through today what those are because those have become very complicated. But in order to have the FTCA coverage, as you know, you have to annually reapply and get deemed to be covered. Until 2017, I think the process for being deemed was pretty much the same for quite a number of years and was not all that complicated. This year, it's gotten a lot more complicated because first, when they issued the instructions, they said that you had to have been doing risk management already, even though they never told you before you had to do it. So they sort of put a retroactive requirement in, which is great and consistent with a lot of things the government does. And now, since then, they've issued the compliance manual, right? With compliance manual, replaced the prior manual, and the prior manual did not address FTCA. That was always a separate, animal that was treated differently, was never part of OSVs and was never included in the manual. They've now come along and said that it is going to be included, at least partially, in the OSV. And they changed some of the requirements in the new compliance manual from what was in the FTCA application, which they issued, a month or two before they issued the compliance manual. So it's a little bit difficult to know what they're going to follow exactly. As we go through this presentation, we'll point out where some of the inconsistencies are and help giving you some guidance for how to get there. What's very important is that you all submitted your applications and hopefully you all got approved and have the FTCA coverage in place. And you might say, okay, I don't have to worry about this again until next summer when I'll just go through the regular panic like I do every summer and put things in place and try to get it done. However, unfortunately, with regard to risk management, when you submitted your applications in July, you promised to do certain things that have to take place throughout the course of the year relating to risk management and identifying goals and doing training and reporting to the board and things like that. And so if my personal view is that for this year, they were pretty lenient and as long as you put something reasonable in, they accepted it. But that come next year where you now had a year to be prepared, you have to show that you actually took some of those actions. And so we're going to walk through today what some of those practical things are. I should have started at the beginning. I apologize. I'm here with Sandy Jensen, my partner. She's going to walk through most of it, and I will jump in like in prior webinars with thoughts here and there. Also, if you want to submit questions, the regular process that's up there to submit them, is in place. If we have time at the end, we will get to them. We previously have not had time, so I don't know that we will, but if not, we will respond to you separately offline after the webinar. And with that, I'm going to turn it over to Sandy.
Okay, thank you. Good afternoon, everyone. I think Jeff did a great overview of the Federal Tort Claims Act, and as he said, it basically provides coverage for any malpractice or health-related claim for functions or services provided within your scope of project. And to be eligible, You have to be deemed a federal employee that would be qualified for protection under the FTCA. And if you have this protection, the FTCA would compensate people who have suffered personal injury due to malpractice or negligent or wrongful acts. So how do you get coverage? As Jeff explained, you have to submit an original deeming application and then every year a redeeming application. And after this 2018 FTCA application, HRSA, as Jeff mentioned, they released an FQHC program compliance manual that in some cases tweak the requirements of the FTCA application. And so we'll mention what the FTCA application required, and then if those requirements were tweaked or revised in any way by the compliance manual, we'll mention those as well. So this year's FTCA application was broken down into 4 sections: risk management, quality improvement, quality assurance, credentialing and privileging, and claims management. And as Jeff mentioned, the risk management one was, for a lot of us, entirely new and required a lot of documentation, and for the health center to describe processes that HRSA thought should have been in place.
I'll just add that with regard to the application, coming up with risk management, Sandy wrote about 10 of them, so I'm not sure there's anyone who has more experience with her on this issue.
Thank you. Okay, we'll start with risk management. So this year's FTCA application required FQHCs to describe their ongoing risk management program. So you had to have one, and it had to be ongoing. And the purpose of risk management was to reduce the risk of adverse outcomes that could result in medical malpractice or other health-related litigation. You had to identify, as everybody I'm sure recalls, you had to identify a risk manager who was in charge of the program. And at the time of submission of the application, the risk manager had to complete annual healthcare risk management training. HRSA identified key components of the risk management program, and it included all of those that you can see on the slides: compliance, event investigation, root cause analysis, and follow-up. They wanted you to identify and respond to trends. Claims management was a part of it. Also reporting and managing adverse events and near misses. You also had to describe your policies that reduce the risk of adverse outcomes. So they indicated that your policies are really your goals. And then later on, you also had to talk about your operating procedures. And so where your policies are your goals, your operating procedures would be the day-to-day activities that you put in place to meet your goals. So your policies had to identify your goals to reduce the risk of adverse outcomes. HRSA specifically focused on certain areas, including triage, scheduling, missed appointments, and intake. So for example, for scheduling, did you make sick visits available in the calendar? What did you do if somebody walked in? Missed appointments, do you follow up or do you note it in the record? Triage, if somebody presents with certain symptoms, are they immediately seen by a nurse? HRSA also identified certain key areas of review for risk management, including hospital tracking, diagnostic and lab tracking, and referral tracking. And for these areas, they required you to upload your policies. And so we'll just break down each of these required policies that you had to submit to make sure that you're aware of what has to be in them. So for the hospital tracking policy, HRSA required that the system include certain information, as can be seen on the slide: patient information, date of admission, reason for the visit, follow-up, documentation received, documentation you requested, including the dates requested. And the FTCA application required that the policies include notification of hospital admissions and emergency department visits. And they specified that this included patients sent to the ED by the FQHC and also those who entered the hospital on their own. Now, one of the changes that the compliance manual made was they only required this of those patients sent to the ED by the FQHC and eliminated the requirement that the FQHC obtain notification from hospitals on patient admissions. They understood that it was difficult for FQHCs to always get information from the hospital, so putting this burden on them would be difficult.
I think that you've heard me talk about this in the other webinars. This is one of the most difficult things, and we went to the fact that HRSA didn't understand that the hospitals are not waiting for you to come and be able to report to you. So this is very helpful in terms of limiting the need to know about admissions. Right? You still do need to know about the discharges, and you still need to know if you've sent a patient, but that's a lot easier if you sent a patient to be able to follow it.
Exactly. You still have to try to obtain the hospital discharge and follow up. Oh, and also you have to include obtaining hospital discharge follow-up instructions and lab results in your formal written referral arrangements. That should be included in the terms. Okay. Excuse me. Moving on to referral tracking policy requirements. HRSA required that the policy have to include defining the referral type. So is it a specialist referral made by a practitioner of the FQHC? Is it a patient-initiated referral where the patient may call up and ask to be referred to a different practitioner? How was it initiated? By whom? The process? And by process, is a form filled out? Does it go to a special department? And then referral tracking, the frequency of the follow-up. You had to identify who the party was that was responsible for follow-up. You have to document follow-up activities, status, patient compliance. So that was an important one too. Is the reason why the referral wasn't completed because the patient was non-compliant? And then if the patient was non-compliant, what steps are you taking to help the patient comply? So does the patient need help in setting up a new appointment? Does the patient understand the importance of the referral? So the policy also had to include documentation in the patient's medical record of follow-up efforts, frequency of attempts to obtain documentation from the provider, and how you did it. Was there a phone call, a letter? The third type of policy that had to be submitted was the diagnostic and lab test tracking policy. So they actually wanted to see both of these components in one policy. So the policy had to include tracking of both diagnostic testing and lab testing. And they identified certain tracking elements that the policy had to contain. So the date the test was ordered, the ordering provider's name, list of tests ordered, date the test results were received, who reviewed the results, follow-up, and communication of results to the patient. Now, the policy had to define normal, abnormal, and critical values for each lab and provide a time frame to communicate the results back to the patient. So, for example, critical values, the policy could say something like critical values, follow up immediately, by telephone. You would make so many attempts within the hour or two. Normal could be by either telephone or even perhaps paper. And that's an interesting point. HRSA specifically required that all results, including normal results, be communicated back to the patient. And so I know that, maybe that was unclear to some of you, and maybe normal results weren't communicated back, but they specifically said all results, including normal results, had to be communicated to the patient. So more goes into this policy. Other issues to address: how to communicate the results back. Again, are you going to call or send a letter? And they also focused on procedures to contact the contact a backup provider. So if the ordering provider went on vacation, was there a backup assigned to receive the test results and communicate to the patient? How are you documenting patient contact attempts and tracking and monitoring critical values? And also, this has to be a part of QI and QA. So making sure that all of this test tracking is being completed, and if any issues are identified, they're reported back to the QI/QA committee and see if any modifications have to be made. And again, as I said before, policies are really goals, and operating procedures are activities to meet those goals. So as part of the application, you have to describe your risk management operating procedures. And so they specifically wanted you to include activities that identify the areas of highest risk to the FQHC. And then how do you mitigate those risks? And they gave some examples or ways that they wanted to see you mitigate the risk. It included establishing or using clinical protocols, maybe training or retraining of staff, or it could include medical staff supervision.
Right, and I'll say that on the practical level, right, from what we talk about today that relates to risk management, the most important thing, in my mind, three most important things. One is making sure you have the policies in place. The second is training, and the third is the practical, identifying areas and figuring out what your goals are going to be and what your achievements are with regard to those goals. So kind of like you do for QA, we might set quality metrics and measure where you are on that. You need to do something equivalent for risk management. At the end of the risk management session, in a few more slides, we're going to go through some specifics and some areas that of ideas we have that you could focus on and walk through it and give you some of those ideas. But to me, this slide really represents the hardest part. Okay, now I put the policies in place. I'm going to do the training, but what am I actually doing to show the government next year that I did something? That I measured activities and set goals and, and reported those to the board, by the way, and had the board approve them.
Further activities that are required are documenting, analyzing, and addressing complaints and near misses. So, they focused on this a bit. You have to be able to identify and track near misses and complaints, and then take action to prevent or minimize future occurrences. So maybe there's a leak somewhere and there's a puddle that could cause personal injuries, and that, someone was almost hurt. That could have been a near miss. And then what action did you take to fix the leak to prevent any kind of injuries from occurring? As Jeff was saying, you have to set and track progress related to the annual risk management goals. So you have to identify the goals and then continuously track the progress at meeting those goals. Another important component was risk management training, and we'll talk about that a little bit later. They identified specific areas to focus on with training. And then reporting back to the board. They require an annual risk management report for the board and for key management staff. And the FTCA application also required quarterly risk management assessments, and it was unclear what these assessments should include, but the new compliance manual clarified that the centers have flexibility to decide how to conduct these assessments. As I mentioned, training is an important component. They identified certain areas that should be included in the training plan, and training should outline required courses for all staff, both clinical and non-clinical, and also training for specialty professionals or those in particular fields. So for non-clinical training of all staff, they focused on HIPAA and medical record confidentiality requirements. Confidentiality was pretty big. Infection control, so hand hygiene and bloodborne pathogen exposure. Obstetrical procedures for specialty staff, and they specifically gave examples of electronic fetal monitoring and dysocia drills. They want to see that staff attendance and completion of training is tracked. In a webinar that they gave to explain the FTCA requirements, they gave a sample of an Excel spreadsheet that listed, staff, the name of the training that was provided, the date provided, when retraining had to occur. They want to see documentation that that your staff have completed these required trainings. And then completion of training must be part of performance reviews and credentialing privileging. So when you're considering whether staff have performed acceptable within the year, you have to look at whether they've met all their training requirements. And then you have to have a process for handling those staff who fail to complete the required training. And that could be that you gave them, you identified that they didn't complete the training, and then you gave them a week, and then it elevates to maybe a referral to HR. But they want to see that you have some sort of process to handle staff who don't complete the training. Now, this slide outlines the governing board requirements. So the governing board has to have overall responsibility for risk management. They authorize approval of the risk management plan. They receive and review the report. They want to see an involved board. So they want to see that the board considered the report. They discussed completed risk management activities, status of meeting goals, and maybe discuss proposed activities that relate or respond to areas of high organizational risk.
Right. So this is a big one, right? Because you can't just, right, hopefully when you submit your FTCA application, you had the board approve the policies, but you have to be able to show actual minutes and documentation of risk management activities that were taken throughout the year. And that means that the board has to have approved, these are the areas we're going to focus on, and then you're coming back and reporting, this is where we've gotten on it. Given that it's been, about 5 months since the application went in, if you have not done this yet, and when we have 7 months left to the year, I would suggest that you want to do this as soon as possible. If you can do it at this month's board meeting, if not, the latest January's board meeting, because we got to get onto the record that the board had understood about risk management and set those priorities. And then you should have at least 1 or 2 board meetings where you report on the success of those risk mitigation strategies or risk goals, and have it documented in the minutes, so that if they ask you in July to submit minutes showing that the board approved it and got updates, you'd be able to have those minutes and not trying to do it all in the June or July board meeting.
And the last point with this one, the new compliance manual required that the FQHC provide documentation to the board showing that follow-up actions have been taken. So the board can make recommendations on follow-up, and then you have to document to them that follow-up actions have been taken.
Okay, so we talked about before that there are certain areas that you can focus on. So actually, before I get even to the things that are up on your screen now, I think you've all heard me say this in prior webinars, which is make sure you take credit for whatever you're doing. So some basic principles are, right, the line between risk management and QA is very unclear, right? If you ask me what is risk management versus QA, a lot of it crosses over from one to the other. The basics, right? QA is about metrics and it's about, patient care and things like that. And risk management is more about avoiding litigation. Now, part of the way you avoid litigation is having better quality metrics, but I think they're looking more for, documentation issues and making sure that the patients get treated appropriately. You document the medications, things like that we're going to go through in a minute. But my suggestion is that any meeting that you have, whether it's what you would otherwise call it QA risk management, you call it both. You should have joint QA risk management meetings going forward. And when you're talking about all these things, you document them in your risk management policies as well, not just in your QA policies. You could choose to have the same person be the QA director and the risk management director, or if not, they should both be present at the meeting and taking notes and be recording them for both of those purposes. Also, we spoke last week about CMS emergency preparedness. So that's definitely a form of risk management, right? Because you're trying to deal with, if you have a fire in your building, what you're going to do. That's a risk management strategy. So when you're doing things like that, take credit for it. Don't, only include it as a separate, we have emergency preparedness, and don't, include that in your risk management, include that in your QA. When you have QA activities like you've always had, include those in risk management also, so you get credit for all the things you're doing. So what are some specific things for risk management? I will tell you that probably some of you on the phone, I've gone to quite a number of FQHCs over the last year and sat and done risk management training with the physicians. And surprisingly, physicians have actually been very interested in it. And what we do is we walk through some case studies and explain to them issues that are at risk for them, right? Something just to keep in mind is there's always been this view that if I'm a doctor in FQHC, I don't really have to worry about malpractice because there's no suit against me and I can't be, there's no money I ever have to pay. I don't have to worry about my insurance going up or anything like that. But there are two things that have changed that in the very recent past. One is that HRSA has now started reporting physicians to the data bank if there are problems. So if there's a case, right, if any of you have gone through a case, right, it gets filed in state court, ends up getting removed from state court or dropped. We have had a lot of success at getting plaintiff's attorneys to just drop the case in state court and have them just refile it in federal court, so you don't have to go through the whole process. But in any case, if they go into federal administrative proceeding and end up going to federal court, if you get to the end of a case and there's a settlement or there's a judgment for the plaintiff, if the federal government thinks that the doctor screwed up, they will go and report them to the National Data Bank. And so now it does follow the doctor, unlike in the past where it did not follow the doctor. So that's important for them and part of how you can get them to focus. Also, I think part of the reason for the risk management is that we've seen, right, when you think of malpractice cases, you think of, the ambulance chasers as being the plaintiff's attorneys, and then very specialized attorneys being defense attorneys. And when these cases get to the federal government, what you have is attorneys working for the federal government who are otherwise prosecuting crime, RICO and things like that, or doing sophisticated things, or working for the government because they want to have great experience, all of a sudden now becoming malpractice defense attorneys. And I can tell you from experience and having dealt with them, they hate these cases. And so they try their hardest to find a way not to take the case. And one of the things that, again, I believe is why there's some pushback on it is they're saying to HRSA, look, you can't just tell them they're covered and they don't have to do anything to try to mitigate. You got to find some ways for mitigation. And so some of the things that are on the next couple of slides are things that you could focus on. Again, you don't have to eliminate it, just like anything else you do, right? In QA, you have patients with diabetes and you want to have, do some testing on them. You don't say we're going to get 100%. You say if we're at 7% now, our goal next year is to get to 10%. Here also, your goal does not need to be to eliminate these things. It needs to be to improve on them. And you should set measures that you think are achievable. So at the end of the year, we don't come back and say we didn't meet any of our goals, hopefully the same way as you're doing for QA. So what are some of the big things that we see here? So I want to talk about medication errors for a second and follow-up. I was running out of time a little, so I'm going to go quick. But basically, what we often see is that you have someone who's seeing the patient, and that person goes on vacation and doesn't tell somebody else that they ordered something, doesn't tell someone else what happened, doesn't finish their notes before they go on vacation, and now a different provider is picking up what's going on and doesn't know about all the details that the first provider knew, and that led to errors, right? A similar thing happens when you have a provider who's on call after hours and they don't document what happened, and then someone else sees the patient the next day, and that's a problem. So those are areas where, based on your after hours or emergency requirements under the regular HRSA elements, you have to comply with anyway. So again, that should be an easy thing to be able to focus on as part of the risk management. Also, just other things that are easy, right, is you have to, from a HIPAA perspective, you have to keep information secure. We've talked about security, identity breaches, and things like that. And so keeping information secure, that's something you could focus on as well. Okay, so other things that come up is, right, the new era of EMR, right, where some of the doctors have complained and hopefully they've gotten past it, but now it's led to a new problem, which is you just copy the note from the last time you did it. And there have been things issued, I think in New York, OMIG recently issued something about this that basically said that if you just copy, you take 10 records in a row and all 10 say exactly the same thing and all you've changed is the patient's name, or for the same patient, 10 visits in a row you've written the same thing, that's a problem, and they view that as being a non-specific patient note. So these are things that you could focus on as well in terms of getting doctors to actually write real notes. Okay, other things that help, right, is informed consent, actually getting a consent where you're required to, having good relationships with patients, because if you have that, they're much less likely to file a complaint. And if you have a problem within the right context, you would admit to it, I'm not in writing, but in a conversation with the patient, and try to mitigate and see what you can do before it gets to become a major issue. Okay, I'm going to skip over this, but other things are peer review, right? So you're required, well, they've actually changed some of the peer review requirements. They don't necessarily have to do peer review. You could do just annual evaluations, but doing things that where a problem comes up, it's discussed across the board, and we use that as a basis to learn and apply new things going forward, as opposed to just hiding it, is very important. And if you're doing that, again, remember to take credit for it, include it in your risk mitigation. Okay, so we're going to move on to the next topic.
Okay, quality improvement and quality assurance. This was another key area in the FTCA application. So you had to demonstrate that you had an ongoing QA/QI program, and you had to your plan has to outline operating procedures. So again, your activities that address that your services adhere to current evidence-based guidelines, standards of care, and standards of practice. You have a process to identify, analyze, and address patient safety, adverse events, and implementing follow-up actions. And that was like a reoccurring theme. We heard about that also in risk management. So adverse events, that you have to identify them and have appropriate follow-up actions. Your operating procedures also have to address a process for assessing patient satisfaction. So you actually have to somehow obtain information from the patient on how satisfied they are with the health center and services. You could do that through a survey. Maybe your call center follows up with patients. You also have to have a process for hearing or resolving patient grievances. You should have a policy in place, a patient grievance policy. You have to complete periodic QI/QA assessments. Now, the FTCA application just required this to be periodic and left it up to health centers to figure out the schedule. But the compliance manual now requires the FQHC to perform quarterly QI/QA assessments. And they outline what that has to include, and we'll talk about that next.
Right. So this is one of the areas where we have inconsistencies, right? They're saying you only have to do quarterly in the new manual, but the FTCA has always required 6 meetings previously. And although they've said that they're going to make the FTCA fit with what's in the compliance manual, I guess I'm a little bit skeptical about that. So if anyone's asking me, I would tell you still have 6 meetings a year until we've actually seen them switch it in the FTCA application.
Right, because those meeting minutes you had to upload with your application. So we don't want to scramble in the summertime or springtime to try to find meeting minutes that discuss QA/QI. And finally, the operating procedures also had to have a process for modifying services based on findings of the assessments. So if your assessments identify something that is causing risk or raises quality issues, you have to take action based on that, and that could be modifying how services are provided. Going back to the assessments, the compliance manual clarified that these assessments have to be done by physicians or other licensed healthcare professionals under supervision of physicians. And this is key too. It must be done using data systematically collected from patient records. And so that means chart audits and peer reviews performed on at least a quarterly basis as part of these assessments. And you're really trying to identify whether there's compliance with clinical guidelines, standards of practice, and utilization of services. The new compliance manual requires that the assessments also assess patient satisfaction. Again, either your survey or you're calling patients up or giving them a questionnaire when they're leaving or coming in. Your achievement of project objectives, your patient grievance policy, and identifying and documenting any changes that need to be done for service delivery as a result of these assessments. The compliance manual made some important clarifications, including it's up to the FQHC to determine whether the person in charge is an employee or contractor or is employed full-time or part-time. And as Jeff had mentioned previously, this position can be combined with another position at the FTCA. Now, they also stated that the person who's in charge of QI/QA does not have to be a clinical person, but QI/QA assessments must be done by clinical staff. Governing board requirements related to QI/QA. A report has to be provided to the board and key management staff. Sometimes I've seen where the QI/QA policies only state that the report goes to the board, but it also goes to key management staff. And again, as we noted before, you had to upload board minutes that document that the report was shared with and discussed by the board. I think 6 meeting minutes were required. And the new compliance manual requires that the QI/QA policy be reviewed by the board at least every 3 years. So documenting compliance. Again, as we stated before, you had to upload your QI/QA plan, your meeting minutes, the report, and board minutes that document that the report was shared with and discussed by the board. So it wasn't sufficient that just the report was just shared with no discussion. They wanted to see an involved board. Moving on to the third big area that was part of the FTCA application, credentialing and privileging. So in past years, you just uploaded your credentialing and privileging policy, and that was fine. I think you also answered some yes or no questions, and this part was pretty simple. But this year, you didn't upload your credentialing and privileging policy. Instead, you were required to describe your process, which they stated that the intent was to make it more flexible. However, you had to be careful to adequately describe it within the word limit to make sure that all of the elements that were required were set forth in your application. So the FTCA application required that if you contract with provider organizations or you have formal written referral arrangements, the contract had to include certain language, and the language has to make sure that the party that you're contracting with, if they're providing you with providers, that they ensure that those providers are licensed, certified, or registered through a credentialing process, and that they're assessed as competent through a privileging process. So your contracts going forward should make sure to have those that language in it, and this includes formal referral arrangements.
Right. So, like we talked about in the webinar relating to new compliance manual, this is a massive change because you do not need to be credentialing providers that are contracted now. You can just be getting it from the company that's, from the provider that's sending them over.
And the compliance manual also made some important clarifications. Other clarifications that you're not required to employ your clinical staff. You can have contracts and to carry out services in your scope of practice. And as Jeff had mentioned, to verify current clinical competence, before it was stressed that you would do this via peer review, but here you can do it as well through other comparable methods, such as supervisory performance reviews. Other important clarifications, you have the flexibility to determine who has approval authority for credentialing and privileging of clinical staff. So usually we've seen the policies would state that the board has final approval. So now you have the flexibility to determine whether it's the CMO that has the final approval authority for credentialing and privileging. And you have the flexibility to determine how credentialing will be implemented. You can contract with a credentials verification organization, or you can have your own staff do it. The last key area for the FTCA application was related to claims management. And the focus of this was really to make sure that you retain all, once a claim has been filed or you're aware of a claim, that you preserve all the documents, and that you also involve the federal attorneys with the process. They wanted to make sure that any complaints are sent to the Office of General Counsel of HHS. If a claim was filed within the last 5 years, you have to provide details of the claim, but you also have to provide a summary of your internal analysis and what you did to prevent future occurrences. So that's an important thing to remember if you get a claim within this 5-year period that they identify. Also, they require an FQHC to indicate whether you inform patients using plain language that you're deemed a federal public health service employee. And you could do this at your option, either on your website, promotional materials, or within the area that the FQHC, within an area visible to patients. And the last thing we want to talk about is a new initiative that just came about. It was part of the 21st Century Cures Act. It provides coverage for volunteers if certain conditions are met. They're called VHP, Volunteer Health Professionals. They do not receive deemed status automatically just because the FQHC is deemed. The FQHC has to sponsor a volunteer and submit an annual deeming application on behalf of the VHP. So this is specific to that person. The person has to be named in the application, and their deeming is specific to them. Certain requirements have to be met, including the service must be in scope. The FQHC must sponsor the healthcare practitioner. The healthcare practitioner cannot receive any compensation at all for the service from the patient, the FQHC, or insurance, but the FQHC can bill according to the requirements of Section 330, so the sliding fee scale and billing third-party payers. Now, before the service is provided, the volunteer or the FQHC has to post a notice at the site where the service is provided, stating that the practitioner is a deemed employee and of their limited liability, and the person has to be licensed in accordance with applicable state laws and federal laws, and they have to be credentialed and privileged. The FQHC has to maintain all relevant documentation certifying that the volunteer meets the requirements to be considered a volunteer. So they have to maintain a file that has all credentialing and privileging information. There must be a written signed volunteer agreement, a letter signed by the volunteer and FQHC that the volunteer will not receive any compensation, and signed documentation of each off-site activity performed for the FQHC.
Okay, so we have just 1 minute left. So just to summarize, right, as you saw, we spent most of the time on risk management because most of the other things are things we've been doing for a long time, so that's the focus. It's very important, like I said, to make sure that you have the policies in place, but maybe even more important is to have practically identified, these are the areas we're going to focus on, and then measure your success at that and be reporting it to the board and training all staff about it, right? The To me, if you have your annual staff training and you spend a minute on the FTCA, that's probably not enough. I think they're looking for something more specific about it. I think that most likely with regard to the physicians, or I should say billable providers, you need to do more of a training than you need to do with the front desk staff, because this is really more about the clinicians, but you should be a significant training with the clinicians about risk management for two reasons. One, to satisfy FTCA requirements, and the second is to protect you, because one of the things we did not talk about is that we have seen that if there are FQHCs that have a number of claims within a relatively short period of time, HRSA can come back and say, we're not going to deem you for next year. And so that's obviously a very bad place to be. So it's really important, because they are looking to do that, like I said, because the attorneys don't want to handle the cases. So it's very important that you get these things in place and do the appropriate training. Thank you for participating.